Good morning. They obviously don't like me putting me first thing after spring forward, but nevertheless, we will persist. I have quite a busy lecture, unfortunately. It's a big topic. I'm going to try and cover as many areas as possible. I'll touch on some physics, highlight potential indications for ultrasound in OB anesthesia setting, and the use of transthoracic echocardiography. If I could cover all of that topic in the time that I have, the 40 minutes, I'd look like that. And if you guys could have any appreciation for what I'm saying, you'd probably look like that. And the truth is, neither of these two exist, unfortunately. So I just want to give you really a flavor of what is out there for those of you who actually use ultrasound to expand some of your indications. And for those of you who don't use it, to convince you that there's certainly a role and lots of potential applications for the use of that. And I not only do OB, I do regional anesthesia. I've spent most of my life avoiding an airway, and I've spent a lot of my life with the ultrasound device. No financial closures, and we're going to start off with very quick physics at essentially 7 a.m. So why is it called ultrasound? It's called ultrasound very simply because the frequency of it is higher than we can, as humans can hear. So it's very simply, that's how it gets its name. And how it's generated is that you have a piezoelectric crystal on your probe, and you put a voltage through, and it starts to oscillate, and it creates this ultrasound waves. And how it has the ability to detect any differences in tissues is because each tissue plane is going to have a different penetration, a different reflection, and scatter. And what gets reflected back into the probe, it has the ability to pick up two things. One is the intensity of the signal, and the other one is the time it takes to come back. So that allows it to create that whole image that we're able to see, as well as things that we stick in to be able to see it come through. And the two quick concepts you need to appreciate is low and high frequency. So low frequency probes are ones that can penetrate really deep, go very far, but it's going to give you poor resolution, kind of an AM signal. And a high frequency is much higher frequency, much better resolution for superficial structures, not going to get into your deep structures. And then the other image at the bottom there is the Doppler effect. So as images are going towards it distorts the ultrasound such that you're getting some compression of them, and then that Doppler shift is appreciated by the probe, same way as if a car drives past and you hear it going, meow, same sort of effect. All right, so that's physics done, and I thought I'd end off there, otherwise we'll have you all pretty much done. So why is it important to learn or start appreciating the ultrasound? Well, we have a unique advantage in OB is pretty much all of us have that little machine somewhere there because the OBs have been using it for a long, long time. So it's not like we even need to buy any equipment, and you'll see that it has a curvilinear probe attached to it because they're doing abdominal ultrasounds, and with that you could easily do a neuroaxial ultrasound as well as tap blocks. So you can already start doing some of the applications. If you're going to do superficial structures like IV access, you're going to have to get a small linear probe with a high frequency. Likely you have it in your main operating room, but not in your OB suite. So you have two options. You can either steal it from there and bring it into OB, because you can just attach it onto your existing machine, or you can purchase one. If you want to do TE, transthoracic echo, you're absolutely going to have to buy a phased array probe. It's a specialized probe, which we'll discuss later. But the machine is pretty amazing because that one I just showed you can do all of this. The 2D images, which you can see in the top screens, that's essentially B mode, which is a bright intensity, and you can do all of those from transthoracic to tap blocks and neuroaxial placement. M mode is essentially a slice through one tissue plane, and it follows it over time. So it's sort of a video recording of a slice, and this is the IVC going through inspiration. What the color is essentially just a video overlay looking at flow, and remember the mnemonic BART, so blue is away and red is towards, so you can work out which direction it's going. And this is sort of a Doppler equivalent of an M mode. Either you can do a pulsed or a continuous wave. It's a slice through and allows you to appreciate flow patterns in either a specific area or over a bigger dynamic range. So Ed Riley covered vascular access very briefly. What is the state of play? Well, we have pretty much excellent evidence, and we have national guidelines to say that this should be always done under ultrasound guidance. You have less block failure, less catheter failures, less complications. It's quicker to do. It's cost effective even. Studies have looked at it. And the recommendation is that you should use it in both adults and children. And in particular in OB with anatomical changes, there's high risks associated with central line placement. The technique, as was described yesterday, I'm not going to go too much into it, but just to stress the fact that it is important that it's not done as a pre-procedure marking, but it's done in real time. You do need to see the needle going in. You can do, there's confusion always between your image and your needle orientation. If you talk about in plane, you're being able to follow your needle all the way through. Out of plane, you can just see the tip of the needle, like that top image over there. I prefer a out-of-plane approach to at least get into the space, but it is very, very important when you're in your vessel to be able to see the guide wire, because there have been many reports where you see it nicely, you thread it through, and it's actually gone through the vein. So it is very important to see the guide wire, and it's not a foolproof technique unless you do that. Arterial line access was briefly mentioned yesterday, but there's good meta-analysis to show that it's going to improve your success. So while it hasn't become the standard technique for A-lines, it's something that you should be calling for the second you're attempting one if you encounter a difficult arterial line placement, and you'll improve your success at first attempts. Peripheral access, as Ed covered, there is some evidence it's going to improve your success in cannulation. There's quite a scatter of studies, and it depends on how you define difficult access, but certainly all of us who have difficult IV access should be calling for the ultrasound. All right, I'm going to cover two other areas in the pain management domain, and the first is tap blocks and then neuraxial placement. So when tap blocks were first described, it was a purely blind technique. You would feel the iliac crest, you would feel a little triangle called the triangle of Petit, and you would pop the needle through that, and you would feel double pops, and then when you got the second pop, you felt that you were in the right tissue plane. Along came ultrasound, and it changed everything. And it changed everything for two very good reasons. Number one, you could definitively see the tissue plane, so you could make sure you put the local exactly where it has to be, which is between internal oblique and transverse abdominis. And the other thing that changed is your ability to see the spread as you're putting the local in. So that allows you to see that nice lens shape. You can see the transverse abdominis dip down, and you can follow the spread and actually give a more posterior injection, which is important for the efficacy of the block. So we actually have decent evidence, at least Ch.B evidence, that you should use an ultrasound if you're going to do a tap block and not do a blind technique. So this is a more controversial area. There's some people who have adopted this in their practice, and there's other people who feel like I'm very good at epidurals and I do not need help, and I can quite easily manage without an ultrasound. And I definitely used to be in that school. Jose Carvalho, about a decade ago, was banging his drums saying we should all use it, and I used to think it's just because he wasn't very good at putting epidurals in. However, a decade later, I'm complete convert. And the reason is it's going to give you very useful information that you absolutely do not have when you're going to be doing a normal epidural. It's going to tell you which space, and there was a talk earlier on in the program about how bad we are at working out which space. We are only correct 1/3 of the time, and we tend to be 1 to 2 interspaces higher than we think we are. There's a huge variability in actually the spinal cord doesn't always end at L1, L2. You add that to our bad assessment of where we're going, and we actually have no idea where we're going. And when you start using ultrasound, you will start going so much lower with your normal palpation technique. The key about ultrasound is that it establishes midline reliably, and for obese patients, this is absolutely critical. It gives you a depth estimate, so it'll help you know what equipment. It allows you to put your needle in a lot deeper than you would, because you already know within about a centimeter when you're going to be getting loss of resistance. So it gets rid of those false loss of resistances. You can work out which optimal space is going to be best for you, because as you've often experienced, you struggle with one space, you move to the next space, and voila, you could have already known that one space was better before you went ahead, and you get some idea about needle angulation. If for the average patient, it may not be applicable, certainly for these patients is where you would absolutely want to use it. But if you only are taking out the ultrasound in the situation of those two, you're not going to be able to do it very well. You have to do a certain base number of ultrasound placements in healthy patients, thin patients, to have a good idea about how to utilize the technique. It's actually a very easy learning curve. these are all the outcomes, and it's still an evolving field because we always struggle to find outcome improvement in a lot of things. But in small practices that utilize it, actually show less failed blocks after epidural placement, and that's work that Grau and et al. Did. You can decrease the number of attempts and the needle directions, and that's a common theme, although overall it does take longer because you have to mark it and go ahead and do it. It's actually an excellent teaching tool, and when Manny Vallejo looked at it, it was easier to learn than the normal palpation technique. And we actually have level 1 evidence that in patients who are obese with scoliosis, who get randomized to either ultrasound or non-ultrasound, in a Toronto study, excellent study, showed that it leads to more successful placement. I know the money shot will be showing a decreased dural puncture. I don't think we'll ever see that for various reasons, but I think that may be the ultimate one that will lead to change of practice. How you do it? Well, first we have to identify the spaces. So you do a parasagittal approach with your curvilinear probe because you have to get in deep. You don't really need the resolution. You're sliding up. Unfortunately, when you do this, you're not going to have the labels to guide you, so you're going to have to kind of work it out yourself. But actually pretty easy to do. It's a sawtooth pattern created by the lamina as you're going along. There's sort of an interesting is there's your ligamentum flavum, there's your vertebral body, so your anterior complex and your posterior complex, and this is where your cord equina or your spinal cord would run. So you're just going along and counting as you go up. When you get to a space you like, you just slide the probe over and you get what's either called the bat sign, so there's your little bat ears, or the equal sign. And once you've seen a few of these, it's very distinctive, and you can see that. In morbidly obese patients, you will never get an image like this, but what you will always get is midline. You will be able to at least get the spinous process and be able to draw a nice line and say, that is midline. I just have to go up and down. I don't have to go left and right. But in thin patients, you will get a very nice image, and you'll know exactly where your interspace is. You mark it, clean it up, and get going. So it has given you information that you absolutely didn't have before. It takes a few minutes when you're good at it. It's really an easy technique. It's surprisingly easy. And all the references that I've spoken about, you're welcome to look and read a few of those, watch a few YouTube videos, and you should be good to go. All right, the topic I really wanted to cover is transthoracic echo, and this is the evolving area in OB anesthesia, and I will fly through that nice and quickly. So it's fairly obvious. We're somewhere in between the stethoscope going to focused TTE. We will be carrying these little devices around in the future, and the stethoscope will be sitting in a museum somewhere. So we're definitely evolving beyond that. And if we haven't adopted it, there's certainly other specialties that have. Emergency medicine reliably utilizes the technique. Critical care. Anesthesia, only really the cardiac anesthesiologist with TEE. But TTE is slowly but surely becoming an important part of anesthesia practice, and in OB is going to be no different. So there's a lot of, what I like about transthoracic echo is there's a lot of 4-letter abbreviations beginning with F, and this is the first of many. So it's the FATE protocol, stands for Focused Assessed Transthoracic Echocardiography. And this is what a lot of the ER physicians and to some degree the critical care physicians are using as a basic outline. It's been well described, it's been used for over a decade, and essentially it's just a focused examination to try and see structural change, volumes within chambers and the pericardium, and also look for certain pathology in the thoracic cavity. Don't worry about the details on this, but there are several, but FATE is one of the bigger ones. So how do we apply a sort of FATE equivalent protocol to OB? And is there any indications why you would actually want a transthoracic echo? So these are indications that have been suggested as useful. So obviously unexplained hypotension. It's not always just preload hemorrhage. There's sometimes contractility issues going on. Unexplained dyspnea in patients. It absolutely can aid your resuscitation in severe hemorrhage. Do I give more blood, or have I given enough volume and start considering some inotropes? It can help in the diagnostic setting. You need a little bit more of a skill set, but you can see cardiomyopathies, PEs with right-sided heart, and I'll show you some examples of this. So thank goodness for a woman called Alicia Dennis from Australia. And what she has done is she spent a large part of her life studying transthoracic echo, and she happens to have an interest in obstetric anesthesia, and she has come up with the ROS Protocol. So you saw all the other 4-letter abbreviations beginning with F. Well, we have our nice rows. So it stands for Rapid Obstetric Screening Echocardiography, and you can Google it, you can download articles, and a lot of the articles come with supplements as to the basic examination. And the key indications when you utilize the ROS protocols, again, as mentioned, you have postpartum hypertension, you're trying to find a cause. Is it a preload issue or is it a contractility issue? And you can look at potential embolic phenomenon that we may encounter in OB, so air, blood, amniotic fluid. And it's specifically, you're not looking for the actual emboli, but you're looking at the changes in the right side of the heart. There's another application that does come alongside and blends in well with the lectures yesterday about maternal resuscitation. It's a so-called FEEL protocol, or the Focus Echocardiographic Evaluation in Life Support. If you change the life support to resuscitation, like some people do, it's called the FEAR protocol, which is not very reassuring. But it has had a lot of utility. So basically, you have a cardiac arrest, and there is someone who's dedicated to the TTE. They will run in. They'll have nothing to do with the management. It'll be dedicated to that function and that function alone. They will go subxiphoid placement of the probe. They'll video it while they're doing it, and they have interesting things that can come out of it. Well, firstly, you can confirm arrest. I've been involved in several arrests where patients are getting CPR and doses of epi, and just because the pulse wasn't palpable, but actually patient wasn't actually in cardiac arrest. It can actually determine if your CPR is effective, and you can see if you're getting a return of spontaneous circulation. And it is very useful for basic diagnosis that's going to cause that. So you can see myocardial insufficiency because of regional wall motion abnormalities. You can see hypovolemia, which was often a cause of PEA. And you may see PEs or pericardial tamponades, as that diagram, as the picture shows over there. So that's a tamponade, and that would be causing the rest. And if you see it in action, like I've seen in simulations, it actually works pretty well. The problem with all of the TTE, and I've spoken about other applications of ultrasound, a lot of other applications of ultrasound are pretty easy to learn. IV access is easy. A tap lock is relatively easy. The neuroaxial, even though you might think it's difficult, it's actually pretty easy to pick up. But this is definitely a different level. So it takes investment on your own side to start learning the technique. We're still evolving into, I'm still evolving, but the whole field is still sort of trying to learn. The good thing is that we're right at the bottom of that pyramid. That's where the focused one is. We're not in that category up there where the cardiologists lie. So it's really just a base level to get you important clinical information to change your practice. Now there's billing issues. There's, can you bill for something that you don't actually have board certification for, or the adequate training for? So this is still an evolving field, and just watch that space for details, but there are certainly plenty of courses out there that you can get a basic understanding of TTE. So what do you need to start? Well, basically you need the probe. You cannot do it on a normal ultrasound machine. Why do you need this phased array probe? It's a special type of probe. It has a low frequency, so it can see deep structures. It is designed to be able to see moving targets. It's supposed to have only one beam. It has various ones that can then collate a moving target image. So it is absolutely critical to have a probe like that. It also has a very small footprint because you cannot see through bone and you cannot see through air, so you've got to look through these little acoustic windows to be able to utilize the device. So once you get the probe to your machine, you're good to go, and then you start looking. And where do you look? You look in the places that we have little acoustic windows to be able to see the heart. So the good thing in pregnancy is that we have anatomical changes that actually aid the ability for us to actually see the heart. Because of the shifts in pregnancy, the heart gets pushed up and slightly laterally, and it actually improves the ability to see a parasternal as well as an apical view. So you basically put the, sorry, I'm just alternating from side to side, but you put your probe in that direction just to the right of the sternum, and you create an image that's called the parasternal long axis. It allows you to see the LA, the mitral valve, some LV function, and most importantly, the left ventricular outflow tract and aortic valve. It's important that you always see structures in two different views, so you can make a composite image. You don't want to just see one view and make a clinical decision based on that. But that's how you start it. And then you flip the probe 90 degrees, and then you start cutting it in short axis. And this is a great view, fantastic money shot, I think. I think this is where it's very easy to see, and it's one of the better views. You're looking at the mid-papillary level, and it's easy to see because you see the papillae muscles. You have to see that because you could get some shortening and underread it. I'll show you an image in a few seconds. You can see overall if it's global cardiac function or if there's regional wall abnormalities. Then you have to look apically, which is sliding just under the nipple line. Easy to do as well in pregnancy. You may have to get patient to tilt a little bit over to the left. And you can see apical 4 and 5 chambers. So you can actually see the aorta in this view, and you can actually do flow, velocity flows. You can actually determine cardiac output when you combine that with your LVOT measurements. I know this is way too much. I'm just trying to give you a little flavor of what you can see. Now, the subxiphoid, which I showed you, is very useful for a resuscitation situation because obviously it's away from the area of chest compressions. In pregnancy, is not a very good view, or it's quite a difficult view to appreciate, especially before the baby's born, because you've got to get the probe in there. But surprisingly, you can actually still get a reasonable image, but it is not the view of choice. The other two would be what you would utilize. But why we often like the subxiphoid is not to see the heart again, which we've probably seen in the other two views. It's to be able to see the IVC, because IVC is important to give us some assessment of volume status. Now, if you can't get in on this way, you can actually put the probe on that side, on the left, and actually go through the liver, transhepatic approach, to see your IVC. And what you want to do is you want to go 2 or 3 centimeters away from where it enters into the heart, and you measure the diameter. If you do the M mode, which is a slice through that area, you can get this view, and you follow it over time, and you'll measure the difference between that, and that's your collapsibility index. And you can see in that table how it actually correlates with CVP and gives you some idea of volume status. You have to use this in the big picture. You can't just use that in isolation. But this would be an example what I would do in a hypovolemic state. Collapse completely, nice and plethoric, so you can see the differences. You look at the chambers and how much volume's in it. And then obviously this is a real-time phenomenon. So you will try and have a few money shots and hold them. So this is a parasternal short axis. And what you look for is seeing how it's contracting. So in a situation that I saw this, I would look at the wall contracting. You try and look right in the middle to see it's concentrically contracting in towards that central point. So you know that there's likely no regional wall abnormality within the view that you have. So you would be seeing septal and anterolateral. You can see it's contracting all the way down, and it's what's so-called kissing ventricles. So it's completely underfilled. So sometimes with hyperdynamic, it may get close to kissing, but this is clearly not a hyperdynamic state, and this is someone who would need volume. Clearly, the heart is contracting well. Now, you may say, well, how am I going to actually determine if someone's cardiac function isn't very good? As you know, when you ask a cardiologist to do that, they're going to run through a whole set of measurements, complicated measurements, then eventually give you ejection fractures. They can even do estimations of pressure, etc. And is that an expectation for us as that base level focused examination? And the truth is that none of the measurements have been shown to be as good as just visualizing and getting a qualitative as opposed to a quantitative measurement. So you can just train your eye to look at a heart and work out whether the function is normal or subpar or really subpar. And it's really as easy as that. You just have to see enough images. And I'll just show you 2 extremes and show you that you could learn that very easily. So this image over here, if it starts, is basically a normal apical 4-chamber view. So what I'd be looking at if I was looking at that is you look around to make sure there's no pericardial pathology. You're looking at the right ventricle there and the left ventricle, and the valve function. You would always want to look at the comparison between the right and left ventricle. It should be 2/3 the size of the left ventricle. So if I see that contracting and there's a suspected PE, cardiovascular collapse, the likelihood is there's no embolic phenomenon because the right ventricle is not giving me any indication that there is increased right ventricular pressures there. If you look at the contraction pattern, if you hold something right in the middle there, you can see it all contracts nicely towards that point. So there's no regional wall abnormalities, and it's contracting really nicely. So that would be a very reassuring heart. And at some point, I'll be able to do this one. And if you contrast that with that myocardium, It is global function, so it seems like everything's affected. You would not make that assessment global function just on one view, but if you combine it with other views, and you can see it's just contracting extremely poorly. So if you saw that in the setting of a postpartum hypotension, you would suspect a pericardium cardiomyopathy. So not that crazy science to do, and it's sort of fun to see the images. All right, I'm going to move on to lung pathology. A lot of the FATE protocols, especially in the ER, utilize the TTE to see usually more gross pathology, but there's actually subtle ones that you can see with the ultrasound, and a lot of people are surprised to think you can actually see a pneumothorax. So the protocol that is used for lung pathology is called BLUE. I still prefer ROS, I'll leave it at that. But bedside lung ultrasound and emergency it stands for. And what they can actually use it for is detecting all of those as listed. So you can see a pneumothorax, pulmonary edema, pleural effusions and hemothorax, and then a few other esoteric stuff. The bottom stuff is certainly higher level, but the top two are relatively easy, and in fact the top one is very easy to do and has higher sensitivity and specificity for detecting pneumothorax than chest x-rays. So if you ever suspect a pneumothorax, don't call for x-ray, grab an ultrasound and do a quick examination. Obviously air is going to go up, so you can look at the least dependent area to put your ultrasound on, and you want to look between two ribs, so that's where you would do it. And you could actually slide it around to try and see the extent of the pneumothorax, not just if a pneumothorax existed. And what you're basically looking for is a thing called lung sliding. Just before I start the video, so that's the pleura, that white line. It's interesting, we used to think that the air was just terrible. Remember I said, oh, okay, it's moving. So remember I said that air is really bad. It gives you too many artifacts and you're unable to see through air for your TTE, so it's your enemy when you're doing TTEs. Well, we're actually using all the artifacts that you would see when you're doing lung pathology. We utilize those artifacts to kind of give us information. So there's the pleura. You can see it along there. It slides. Some people call it marching ants. You can see it moving along there. It's not just the fact that it moves alongside, but you want to see it moving along there. And every now and then you see these little small B lines coming down, and you can also see the reverberations from your pleura, these horizontal lines, which are called A lines. So if you put the probe on and you see lung sliding, your pneumothorax is excluded and you can move on. So it takes literally seconds. If you want to get a little bit more diagnostic, and there's several other ones, you can put M mode and you slice through, and that's what's called a sandy beach, and that's like kind of the sand coming in the waves. I don't know, someone said it's a sandy beach, so there it is. And then that's called the stratosphere sign. You can see it looks like a barcode sign that looks like a barcode. So if you see that, that's bad. And this is actually showing lung point where there's your pneumothorax, and that's where it ends, and that's where you've got contact. But it's pretty easy to see. It's actually remarkably easy as well. Slightly more difficult, because the diagnostic criteria a little bit more complicated, is for pulmonary edema. And what we do is we look for B lines. So remember I said the A lines are the horizontal ones, the B lines are the vertical ones. These are the ones that come across and obliterate the horizontal lines. This is a gross example of it, but when you start seeing increasing B lines, you've got to worry about pulmonary edema. So in a resuscitation situation, I would put the probe on and have a little look for lots of B lines and be thinking, I might be putting a patient into pulmonary edema. But that's an example of lung pathology. And I'm going to end off with the gastric ultrasound. So as you're aware, it's one of our concerns in OB because women are at high risk for aspiration. And what we have to rely on is purely time-based guidelines, and we follow the ASA guidelines in terms of whether or not the stomach is emptied. So wouldn't it be nice to have an ability to look into the stomach and say, is there actually food or something in there? So this is an area that the Toronto group is working at, in particular Perlis and colleagues, and they've done some remarkable work, but this is really still early days, but you're bored one day and you want to play around with it, you can start seeing if you can actually see something. So what you do is you put now remember you have to get deep in there, so obviously it's going to be a curvilinear probe, so you already have it available, and you want to see deep in the structures, so you're going to have a low frequency curvilinear probe, and this is in the sagittal plane. And if you look in the sagittal plane, what you're looking for is, because you're going to be following the aorta, is an area of pancreas. Unfortunately, again, it's not going to come with a P label. and then you're looking for the antrum. That's the liver. Then you'll flip it over into an axial plane because the axial view is believed to be better, especially when you're trying to quantify how much volume is in there. And you'll be looking for the atrium, which in this case is completely collapsed. There's a pylorus and duodenum or duodenum. I'll show you an example of when there is actually water in the stomach. So there's the atrium filled with water. The image, they say, is a starry-eyed because of a few of the gas bubbles and the water, so you can see little stars in the thing. And then if there is food in there, it's postprandial, it's over there, the atrium, and it's sort of that frosted glass appearance. So you can have a look. So this is still not ready for prime time, but this is the next application of ultrasound. So if you're bored tomorrow on OB, feel free to play around with it. So I've gone through various applications. Obviously, each one would deserve a lecture in itself if you were going to actually want to apply it, but it's very easy to actually pick up these techniques with the exception of TTE that's going to require more concerted, focused effort. And I hope that you consider applying some of these in your clinical practice to improve your patient safety and various other things. And I thank you for your time for both lectures, and that's about it. And you're welcome to email me.